Bienvenue à la session scientifique du département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session. Cette présentation sera enregistrée et disponible sur la chaîne YouTube du département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki ekoweshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Bonjour, bienvenue, hello, and welcome everyone to our June edition of Family Medicine Grand Rounds. My name is Doug Archibald. I'm the Director of Research for the Department of Family Medicine, and it's my pleasure to moderate today's truly global session. And it's my privilege to introduce Dr. David Ponka, who's going to be today's speaker. He's a full professor in the Department of Family Medicine and her Faculty of Medicine, where he strives to combine clinical, educational, and research impacts in global health. He's directed the Besserer Center for Global Family Medicine at the College of Family Physicians of Canada, and has helped launch the discipline of family medicine in contexts such as Guyana, Indonesia, and Madagascar. Although he pursues various scholarly interests and policy initiatives, the common thread is working with vulnerable populations, capacity building of primary care systems in low middle-income countries, and research on integrating mental health for underserved populations, including the homeless. Increasingly, he's applying lessons learned from overseas to the Canadian context. I think that's what we're going to be hearing about today. So David, most welcome to you and actually to many guests that we have online today. So perhaps at some point we may want to do some introductions, either before or after your presentation. I'll leave that to you, but welcome everyone. David, over to you.
Thank you very much, Doug, for that introduction, and welcome everyone. This is very exciting that we have guests from around the world joining, of course from Guyana, also Tanzania, and we expect some guests from Benin. If I've seen correctly, Tamika, Crystal, Kion, Anisha, and Kamta are on the line. I might be missing some. And indeed, thanks also to Lisa Baer, who's our global health lead at the department, who will be saying a few words, sharing a few slides about the state of affairs in Guyana with regards to family medicine and how, like many contexts post-pandemic, there is a crisis. There's a crisis in governance, perhaps, as we are seeing in Canada, also in Guyana, and it would be a great outcome of these rounds if we could, once again, work more closely together on capacity building. So I'll share my screen. I've been Assistant Dean at IGHO under Mark Walker for 6 months now. And Doug, I was really thinking, as I shared with you a month ago, how to present these rounds. I thought, should I just present the first 6 months at IGHO, lessons learned? I decided to work rather around presenting a body of work, including a little bit of work at the Besserer Center, some updates from the Besserer Center, as well as some opportunities that I see in ongoing collaborations around the world for the department. Let me add to our land acknowledgement. Dans les deux langues, je suis très fier d'habiter à Ottawa. Ceci est le logo de la Galerie nationale du Canada. This is the logo of the National Gallery of Canada, borrowed from the Algonquin people. This concept is borrowed. It's the concept of Ankose, where not only everything, but everyone is connected. And that's why it's a true pleasure to see so many people from around the world joining us today. We have a lot to learn from the Algonquin still. And in global health, this ethic, this paradigm of everything being connected between sectors, between global health, planetary health, social accountability is such an important one. I'm also proud to share that we'll be launching a partnership with the National Gallery for the journal, The Canadian Family Physician, for a cover art. So starting in September. So if you have any feedback on those pieces that you'll be seeing on our cover, please let me know as associate editor there. It would be a pleasure to hear from you. So I've been at IGHO for 6 months, and it's been a real treat to meet the team, to meet the various players, and to work between departments, because truly everyone is connected, and no one in global health has the sufficient resources to do it alone. And so it's about finding leverage and connections between programs and projects, in my opinion. The team is wonderful, bilingual. We also are now helping our Bureau d'Affaires francophone colleagues with their stage Bénin. And I think we're making great progress. This was a retreat on June 3rd. One challenge that I see that is not unique to global health or the University of Ottawa is a potential or perceived divide between research and clinical teaching at our universities. And in global health, it's very important to overcome this, again, because of the resource question. We have great strengths in Ottawa, being a diplomatic city, also because the Department of Family Medicine at the University of Ottawa is so strong when it comes to health systems research. And one of my goals is to continue to help merge the clinician and research perspectives moving forward for global health. When we do this, we achieve great things together. This is a module that we presented to the WHO on THC capacity building. That's the QR code there. By the way, if you get your phones out now, you'll be able to see the references that I use and also participate in a Slido on the next slide. So if you have your phones, please get them out and get the camera ready. So when researchers and clinicians work together in global health, this is what we can achieve. Research divided from clinical practice can be less relevant, and clinical practice divided from research can be less evidence-based. And in global health, it's especially important to work together. And we have, as I say, great strengths at the BRI, at the department, at the WHO Collab Center here, and at the Equity Lab, not to mention the Social Accountability Office of the University of Ottawa, to help us overcome some of these barriers that are not unique to the university. So Doug, I've actually decided not to focus on my first 6 months at IGHO, but rather the W5 of global health, the what, why, where, who, when, and why not of global health, all in view of giving some time to Lissa and our Guyanese colleagues to hear specifically about their needs over the next years.
Very good.
All right. So here's the Slido. Please click on it and join. And there are 3 questions, which is what the free version entails me to. But I like to make this interactive. J'aimerais aussi prendre des questions à n'importe quel moment dans n'importe quelle des 2 langues officielles. So please feel free to interrupt me if you have a thought over the next 30, 40 minutes. and I'll be happy to make this more interactive. All right, so let's go to the Slido here on my screen. This is a bit of an experiment. So are people seeing the first question? The Slido
Yes,
number.
David, I've got it on my phone.
All right. The Slido number, by the way, if you didn't have a chance to scan the QR code, is right here, 1754571. What percentage of people in low-income countries have received one dose of any COVID-19 vaccine to date? So countries such as, sub-Saharan Africa, parts of Asia, parts of South America. Although officially, I'm told Guyana is now a middle-income country, and so is Benin, which is great progress. 13%, 10%, 40%, 25%. We have a very informed Department of Family Medicine. I'll give another minute. Oh, here, 25%, 50%, 10%, 35%, 10%. Okay, fascinating. Question number 2. I like this question. I used it a year ago at the department community of practice rounds, the research rounds. What, or rather, rank these concepts from narrowest to largest. Definitions are important in global health, planetary health, social accountability. Which of these concepts serves the individual, which serves communities, which serves a broader public? Rank them from narrowest to largest in terms of scope. Number 1 being narrowest, number 4 being widest scope on a population basis. I'm going to give this one a bit more time. And part of my goal today is to present or represent, because many of you have heard of this emerging discipline of global primary care, which is being led by many institutions, Australia, UK, but also Canada. We have a strength in being pluralistic, I believe, as a country, and a strength in looking at the system level. Interesting. So we have community-oriented primary care as a mild first, primary care, primary health care, public health. Very interesting. I'll give another minute. And the literature is still quite full of different definitions, but I will present the one that's the most accepted and the ranking that is the most accepted today. And I'm glad to see that it does not quite match up to what I'm seeing here. And so my rounds hopefully will be somewhat useful. Last question. What are the 3 preferred global health partners of the University of Ottawa? If you joined early, I mentioned them and you get an advantage. We have many partners around the world, and there is, as I say, an Office of Internationalization and an Office of Global Health under AGHO. We are trying to work more closely together because there's overlap. One is perhaps more about outreach and capacity building, and one is more about the internationalization and the educational exchanges and the business opportunities. But in fact, we can achieve more together. All right. Oh, someone mentioned Madagascar. Very interesting. And I will mention Madagascar today. All right. So let's finish the Slido. Thank you very much. I hope that was engaging. Let's go back to the PowerPoint. Good. Can folks see? So moving to the what of global health and the definitions, and a little bit about this emerging discipline of global primary care, which we are co-leading with others in the world. And also a brief presentation, even though Doug, today is not a research presentation, on FMVAX, which I presented at the Research Community of Practice, because it was one of the sentinel studies of the Besser Center. So I think we all know what primary care is. Community-oriented primary care is the CHC model. It's primary care with a neighborhood focus. The college might call it the patient medical neighborhood, primary care being the patient medical home. Primary healthcare is a whole of society approach between sectors, where every ministry tries to be a health ministry, and certain countries do this quite explicitly. Certain countries in the Gulf and elsewhere in Asia have ministries of happiness and wellness, longevity, healthy aging. Really, why shouldn't every ministry be a ministry of health? In Canada, in the US, primary healthcare embodies this approach around integration, around multi-sectoral policy, and empowering communities to have their voice heard, as, for example, Tara Kiran is doing here in Canada with our care work. We just interviewed her, Nick Pimlott and I, on Monday for a CFP podcast, and I look forward to your feedback on that. So that's primary healthcare. And primary healthcare has, by definition, a transdisciplinary approach. I owe Ella another $1 now. This is something she published a couple of years ago. We in primary care are sometimes still stuck in multidisciplinary collaboration, where we see patients in parallel. Community-oriented primary care is by definition interdisciplinary, people working much more closely together to serve their communities. And we see differences in outcomes, don't we? We know this from some of the work of our colleagues at the department here, that community-oriented primary care models achieve better outcomes. Primary healthcare is truly transdisciplinary. And all credit to Ella's mom for her talent. Sometimes art helps us understand these concepts better. So primary care and public health equal primary health care. There's different terms out there. The college calls the community-oriented primary care model the patient medical neighborhood, but it's important to see that primary care is a subset of community-oriented primary care, which together with public health creates primary health care. Primary health care is an overarching concept, and we are not therefore the sole keepers of primary health care, but we are experts in the clinical provision of primary care services. These definitions are important because when we write and when we advocate, we should not overpromise, and we should make sure that if we're talking about primary health care, that we are partnering with the right people around the table, including communities, most importantly. Here's a link to a fascinating primer that my colleague Catherine Rouleau at U of T produced, and many of you have seen already. What's important about these concepts is the overlap. And as I was saying in my introductory remarks about the overlap between clinicians and researchers, health system researchers, I think it's very important. I think the impact is to be had in the overlap. And this is a policy brief on how to increase the integration between primary care and public health to advance the health of our communities. And I think it's safe to say that at times we're siloed. And we realized this in the pandemic, didn't we? Where vaccines were given by our public health colleagues. I carried a single batch of vaccines to Attawapiskat, but here in Ottawa, I had nothing to do with vaccinations. And yet the trust that is given to primary care providers can be helpful to public health, and vice versa. The reach of public health is essential to primary care providers. So I think this is a real emerging area of interest for global primary care, and to help inform health systems between contexts. And that's one of the key things about global health. It's not just about export, it's about importing and co-learning from other countries. And let's face it, in Canada, we are in a primary care crisis, and we do need some novel models and some novel ideas. So global primary care is very much this. It's focused on models of care with an emphasis on generating, synthesizing, and applying cross-border learning. Critically, it's bidirectional, and critically, it works at the health system level and includes transcendent global challenges such as climate change, aging populations, and issues that our colleagues in social accountability and planetary health deal with just as much. And so I'm very optimistic that we have many, many elements and many strengths at the university to help become a real hub of global primary care, as other institutions have become. This one's for Claire. I don't know if I've shared this with you, Claire, yet, but I don't see global health, planetary health, social accountability as intersecting Venn diagrams. I see them as slight shifts in a frame of reference with very similar methodologies around equity, community engagement, and system level thinking, but applied to different denominators and different, by needs, urgent problems. And look forward to working on this with you and with Hussein Malou on these concepts. So global primary care is a strength here, can become a strength here, a growing strength. It's also a strength at the University of Oxford, where my colleagues Luke Allen and Michael Kidd, previous president of Wonka World, are housed, and they are leaders in defining this emerging area of practice, discourse, and academic scholarship. And I'm pleased to say officially now that this is emotional for me because the Besser Center was at the College of Family Physicians for 10 years, since 2015. And I was leading it for about 5 years. Great team, great community, both within and outside of Canada, including our colleagues in Guyana. It's moving officially now to the University of Oxford, UK. Dr. Sadok Besroor has given a generous donation that will permit a professorship in perpetuity. There are professors at Oxford since 1251. And the idea is it won't be privy to some of the political forces that unfortunately made it succumb here in Canada. In Canada, we have a crisis and people are rightly saying, well, what about us? Members are rightly saying, well, what about us? And perhaps we need to make the point even more strongly that the answers don't always lie within the room, but between rooms. And we have so much to learn from others. It's not just about export. It's very much about import, in my opinion. But the Canadian connection will continue, namely because of the strength at the University of Ottawa, and namely because of others, University of Toronto, Memorial, Laval, very involved in Madagascar, Université de Montréal. And that brings me to my point that Oxford needs our help for la voix francophone. Oxford will need our help to think of West Africa, to engage West Africa. And Oxford will need our help with Canadian roots in pluralism. And let's face it, we still have enormous strengths and enormous respect around the world when it comes to family medicine and the patient-centered model. We have enormous respect around the 4 principles, the 9 principles of McQuinney, and that's not going anywhere. And so I encourage all members of the departments to keep their eyes open for opportunities. And I promise to do my best to keep informing through the newsletter and otherwise opportunities at Oxford and in global primary care. So one of the ethics besides reciprocity and co-learning and bidirectional learning is capacity building. And this is a paper that you co-published, Crystal. Congratulations. I hope you put this on your CV often. It's a paper that gets cited, and you should be very proud of this. This paper in BMJ Global Health was an early achievement at the Besser Center that really talks about the need for layers of mentorship when it comes to building not only a clinical discipline in an emerging context, but also the scholarship around this discipline of family medicine in emerging contexts. And it talks about the need for train-the-trainer models and the need for trainees to work independently. And this is something we can perhaps reflect on here. To what extent do our trainees, when practicing in research, work with existing programs of research and existing teams? And to what extent is the prerogative of making them work independently with their own data sets actually realistic of the real world of research? So this publication I highlight because I knew Crystal would be on the line. Congratulations, Crystal and others. And this is the kind of work we can do together. So before moving on more to the why, let me finish the what of global health. And very briefly, even though this is not a research presentation, tell you about another sentinel study at the Besser Center that was led by Sumit Sodhi from the University of Toronto and colleagues around the world, built on a paper from Felicity Goodyear-Smith, looking at early outcomes of the pandemic and whether strength of primary care influenced those outcomes. She did not find that strength of primary care systems influenced early outcomes during the COVID-19 pandemic, mortality, but the integration, once again, between primary care and public health was significant. We took this concept of a cross-sectional study, which is not perfect. These are perceived data, self-assessed data, but triangulated against COVID-19 vaccination rates. It was a multilingual study, translated to all UN official languages and Portuguese. Why Portuguese? Because of the strength of community-oriented primary care in Brazil. And we received 500 responses from 50 countries. I put some work into making this work. Hopefully you can see that. This is our response rate are from around the world. That was the strength of the study. The weakness, of course, was these are self-reported data, survey data on the perceived integration of primary care and public health around the world. And when we triangulated that, these are the responses around perceived integration. We perceived ourselves in Canada as being quite integrated between primary care and public health. As I said at the outset, I'm not sure I fully agree. There are models of care where one is more integrated, sees more integration, and sees more community-oriented primary care, namely in Brazil, Indonesia, and elsewhere. And we could learn from others in that regard. These are our results. So perceived, once again, that's the weakness, perceived integration of public health and primary care against rates of vaccination. And one can see a significant relationship in low middle income, upper middle income, and a trend in high income countries. Low income countries were not analyzed in this model because of insufficient responses. We only took and analyzed responses where there were at least 5 per country. And I'm quite proud of this work because it shows that in low middle income and upper middle income countries especially, that integration is especially important. My interpretation is integration becomes less important when you have all kinds of resources. And as we know, we had an oversupply of vaccinations in Canada at one point and actually missed the opportunity to share with the world. So this was published in PLOS ONE in January and is an example of the kind of studies that we can do as global health, global primary care practitioners between institutions, where one could not analyze this data if one did not have the rich contextual background of transnational approaches. All right. The why of global health. Yes, there's a moral imperative. There's also a health imperative, as I've been starting to argue. Above all, though, we're a university, and it's about our learners. And if there's time, and perhaps this is more for the discussion, Doug, my goal is to be done around 8:40. Oh boy, I have some work to do, to give some time for Lissa and Guyanese colleagues, and then 10 minutes of discussion. So there is a moral imperative. These are supply of physicians around the world, where the surface area of a country represents the per capita supply of physicians at the country level. We see some countries being ballooned, and we hardly see others, namely in sub-Saharan Africa and parts of South America and Asia. This is a moral imperative. Yes, we have a supply crisis here, but once again, it's not just about the supply of physicians, it's about sharing lessons and potentially efficiencies under times of duress and under times of undersupply. This was one of the Slido questions. So in low-income countries, only 30% at last count, just over 30% of people have received even 1 dose of any COVID-19 vaccine. And so this brings me to the health imperative. Yes, that's a moral travesty, but as we know, viruses know no boundaries. And increasingly, issues around planetary health and other issues around global health security, a term I've been using much more since the pandemic, not just global health, but global health security, require collaboration between countries. And in future pandemics, if we reproduce this kind of inequality, will see more variants for longer times and more of a threat to even rich countries. This is a concept that was hammered in my master's at the University of London, UK, the concept of equality versus equity, which we all understand, but also the concept that inequality is bad even for rich countries. So countries that see more inequality, and I think we recognize that in pockets of Canada, countries and contexts that see more inequality see worse health outcomes at the country level, at the neighborhood level, and between countries. And so this is a key concept in global health, is that equity is not just for those key populations, it's for the whole population. It's an outcome, it's a benefit for the whole population. And that's, I think, really, really important to emphasize when we're talking about global health and global primary care. And the key reference for that is here, Wilkinson and Pickett, a very well illustrated book on this concept. So I'll finish the why of global health with the argument around reciprocity once again. We are leaders at the University of Ottawa, thanks to people such as Manisha Kulkarni, Alison Krentel, around some of the ethical implications of global health work, how to ethically approach a global health partnership, and how to make sure that it's embedded in bidirectional co-learning. We have a lot to learn from others around efficiencies and integration, and how also to make sure that we don't work in silos between universities in Canada. There's a section in this report on collaborating with other universities in Canada and not undertaking competitive kind of framework. And this is something I recently was able to do with the University of Alberta in reviewing their international programs. So I encourage folks, and I'm hoping that this turns into a live, living document and not just a one-time document. It's a really strong document that we can be proud of at the University of Ottawa. Above all, though, the why of global health is for the university community. We are a department in a university, and we have a strategic plan which is based on international impact, on francophonie, bilingualism, and improved student experiences. Students invariably tell us about the transformational is the word that comes up aspect of global health electives. And I think it's not about necessarily traveling outside Canada. It's about seeing a different context. And certainly one can travel within Canada and think about equity and how to be service-oriented, community-oriented, service-driven as a learner and for one's career. And increasingly, another thing we're talking about with the Department of Social Accountability is these experiences can be student-led, and that in itself it's transformational. There's great evidence that we're gathering as a community around electives in low to middle income countries being an important pathway for fostering a long-term commitment to equity and service among Canadian medical students. And I think we can contribute to this evidence through longitudinal tracking, monitoring, cohorts, and tracking their career choices. And I think family medicine can be a leader in this because of the community we're building. A little bit about the IGHO. I work with Mark Walker, who I really respect, who's got great expertise in AI and health systems around the world. He speaks Mandarin, by the way. And so we're increasingly working together in not seeing global health and internationalization as siloed either, as there being an overlap. This is our contact. And as I say, my goal is to be a catalyst for the departments in bringing this work together. We have many opportunities to engage, not only in mobility, but in educational programs and in our concentration, which we're trying to improve. And please expect some communications on the concentration in global health and social accountability, which is open to all our learners. There's also some limited funds for faculty mobility for our preferred partnerships in Tanzania, Benin, Guyana. These are the 2 deadlines, September 12th being the next one. We'll always entertain your questions, however, and if there are remaining funds, please feel free to reach out at any time. So the where and with whom. I think we've come a long way from the times of caravan trips, paddling up rivers, and realizing once we land in a certain community that they don't even speak Spanish, but they speak an indigenous language. This is not global health. Global health is about capacity building and year-round partnerships. It's not about caravan models. It's about building not only capacity, but competency. I think Lisa will tell us more about that in her slides. And so that's why the whole idea of preferred partnerships is important. We cannot just do initiatives at the individual level. We have to do it at the institutional level to actually make a difference. And Andrew, thank you very much for joining us. I don't know if Michael Burke is on the line yet. He was going to try to join, an Australian GP from Tanzania, where I'll be traveling with Haley Morton in about a month to see if more capacity could be lent to their primary care strengthening. So glad to see so many colleagues from Guyana here today. And that's the whole point of the rounds. It's not so much about what I say, it's really about opening up these rounds to our preferred partnerships to help build capacity, but also to learn from you. We do have a crisis in Canada around capacity, around access to care. 20%, approaching 20% of our patients here in Canada don't have a regular family physician. How do you seek efficiencies? How do you seek integration? And the answers are not always within the room. We do have some other international partnerships that are not in low middle income countries, namely Kuwait, UAE, France, China. More about that next time. I do want to get through some of these slides. What's interesting, and this is a study that was done at the Besser Center as well, is to look at the state of family medicine and primary care around the world. We have another map about length of residency training, and Canada has the shortest residency training in the world, as many of you know, as you all know. But here, this is interesting. West Africa does not have family medicine, and we know this from a recent trip to Benin. However, there is great momentum. I'm not sure if si quelqu'un s'est rejoint du Bénin, mais merci beaucoup pour votre engagement, pour votre réception. And thanks to a program, la Bourse Canadienne de Développement International, we can truly say that we're becoming reciprocal in our relationship. And we are here as partners to help you build primary care, and hopefully it will include the discipline of family medicine. It's very interesting to note that France did not have family medicine until the year 2000. You can see that on this map. And part of global health is looking historically at some of these trends to try and understand them. One of my proud moments at the Besser Center was a call with the Beninese Ministry of Health, where a fellow from Madagascar, someone mentioned Madagascar, and we hope that that will be an ongoing partnership for Canadian universities, Francophone universities. Someone in Madagascar called into the Beninese Ministry of Health to, and Lisa, you remember this, to share her experience. She's an internist who is passionate about primary care family medicine and is launching that with the help of some fellowship funds from Canada and now from Oxford, launching the discipline of family medicine in Madagascar. And that was a proud moment. Lisa was a big part of that. Let's hope that kind of South-South collaboration can continue as well. And that's another ethic that is important in global health. So the when. Lisa, I have about 5 more slides, and then I'll project yours and we'll have time for discussion. This is great. So why now? I mean, the Declaration of Alma-Ata was in 1978. The Declaration of Astana was 30 years later. It declared now more than ever. It's not the first time that we are hearing now more than ever the urgency around primary care and primary health care as a foundational model for health systems. Why now? Why should it work better now? Well, part of the reason is that countries are evolving. Benin is no longer a low-income country, but a middle-income country. Same in Guyana, I believe. You can tell us more about that. But hence, we see an epidemiological shift from not only communicable disease, but non-communicable disease being much more important. It's still a shift. It's not fully shifted as we are seeing in Canada and the US, but this means that the integration between different sectors is even more important. And in fact, when we look at the evidence, I was so happy to find the study when I was giving a talk in Benin. This is an amazing study looking at a meta-analysis of first-level capacity building efforts and their impact on all kinds of outcomes, including mortality and disability-adjusted life years. And low-income countries perhaps don't benefit as much from health system capacity building efforts as middle-income countries do, both lower and upper. Why? Well, perhaps low-income countries need really, truly multi-sectoral collaboration around hygiene, around determinants of health, around the economy. Once a country reaches the middle-income bracket, that's where the goal of primary care, family medicine strengthening can really be seen. And I'll be using this slide more in trying to explain that the time is now, more than ever, I believe, for contexts such as Tanzania, Benin, and Guyana. And we are very willing partners if this makes sense and if you agree. As I say, le BCDI, un programme canadien qui a donné 750 000 $ pour le Bénin pour amener des étudiants ici à Ottawa, a fait beaucoup pour assurer la réciprocité de nos programmes. Et c'est grâce aux efforts de Marie-Hélène Chaumienne, de Megan et autres qui sont impliqués depuis longtemps et du Bureau d'affaires francophone au Bénin que l'on voit ce progrès. On voit aussi des collègues du département de la Faculté de l'éducation s'impliquer au Bénin et il nous fera plaisir de collaborer et de coordonner nos efforts. I'll just finish about the why around the fact that the dean seems to be very supportive, not seems to be, she has assured me that she's very supportive of global health because she cares about key populations, she cares about social accountability, she cares about planetary health and what we can do as a university. This is a fundraising agenda that we've presented to Melissa, including not only global health, but global health security, access to primary care, the overlap with planetary health, and you'll notice there mental health integration. Our psychiatry colleagues, including Doug Green and Susmita and others, can be true leaders when it comes to demonstrating the importance of capacity building at the primary care level, which includes mental health integration. Family medicine is the only discipline which weaves seamlessly between mental and physical health. Our psychiatry colleagues understand this, and they are willing partners and natural partners in this kind of work. This is my last slide, Lissa, and it's about the listserv. Please stay in touch. I'm trying to start a listserv. It's a little bit clunky platform, but I think it'll be worth it. Please join. And if you find it too clunky, let me know, and we'll start another method of communication to really help build this community of global health, not only at the Department of Family Medicine, but at the University of Ottawa, where there are so many strengths, thanks to you all, in engagement, in education, and in health systems research. Thank you very much. And it's a real pleasure now to give the floor. Thank you, Lissa, for agreeing to do this. Not only to you, Lissa, our global health lead at the department, but also to our Guyanese colleagues to see how we can be increasingly engaged and re-engaged with them.
Thanks so much, David. This is so great. And I have to say, I'm so happy to see all of my Guyanese colleagues and friends on the call. So I'm just going to give a quick update on Guyana, specifically because this is a partnership that we've had for over a decade now. And things have sort of changed in part because of the pandemic, but various other factors. And I think there's a real opportunity here for re-engagement and for transforming this partnership into the meaningful sort of global health change that we want. So some background about Guyana. Guyana is actually considered a high-income country by the World Bank.
Wow.
Due to their oil and gas sector, but I don't think that it's a high income country in practice or in health outcomes yet. But it's one of the fastest growing economies in the world due to its oil and gas sector. So that's a sort of interesting fact. It's a small country in the north of South America on the Caribbean Sea with a population of just over 825,000. And in 2017, the physician to population ratio in Guyana was 0.2 physicians per thousand people. That has increased since, but the World Health Organization target is 1 physician per thousand. So they have just increased above that target in the last few years, which is great progress. And we'll kind of talk about why. So within 2 years of graduation, about 80% of medical graduates from Guyana will leave to pursue training elsewhere or to work elsewhere. So there's a significant problem with physician retention in all specialties. But in response to this and poor health outcomes and lack of access to primary care, the Ministry of Health in Guyana and the Georgetown Public Hospital created new postgraduate medical education programs. And part of this was the creation of family medicine. So if we can go to the next slide, David.
Yes.
Thank you. So this is a very, very simplified sort of history of our partnership with Guyana. So in 2014, our first MOU was signed between U Ottawa, the Ministry of Health in Guyana, and the Georgetown Public Hospital. And in 2015, the launch of the family medicine program began with 6 family medicine residents who then graduated in 2017 with a master's in medicine in family medicine. So since then, there have been 28 family medicine graduates, 20 of whom are still working in family medicine sites in and around Guyana. So that shows that there is pretty good retention, and that 80% is not what we're seeing with family medicine graduates. So that's, I think there's something we can learn from that. In 2018 and 2023, our MOUs were renewed. Now, things sort of slowed down around 2020 due to the pandemic, and our faculty and visiting Guyanese faculty to Ottawa really slowed down. I visited Guyana in 2022 and was there for a month, and I did some teaching and was able to see multiple sites in and around Georgetown. That was definitely a transformative experience for me. So if we can go to the next slide, I can talk a little bit about how we can move things forward in a couple minutes. So I think there's lots of areas for collaboration with our Guyanese colleagues. I think it's great that we have people who have joined our rounds today, and I think in the future, it would be great to have our colleagues from our priority partnerships join our grand rounds if that's a possibility. Inversely, there is opportunity definitely for us to support academic days in Guyana. So the academic days are on Thursday afternoons, every Thursday afternoon for the family medicine program. And we are actually in the same time zone. So it's not that complicated in terms of timing. In discussing the needs of the program with Dr. Daniels Williamson recently, the care of the elderly is a big subject that I think our colleagues can use in terms of teaching. So geriatrics, palliative care, neurology are subjects that if anybody is interested in teaching, or if we could get our enhanced skills residents to offer some teaching, that would be a great opportunity for collaboration and for some global health teaching and experience. In terms of competence building, having sort of bilateral visiting residents would be great. Having that program sort of restart for our residents to visit Guyana, but also for Guyanese residents to visit us here is something that we're looking at as a possibility, because this did happen in 2014-15, and it was a great experience for everyone. And then I think when we have visiting residents from any program, it's always very appreciated by everybody. So if that's something that we can look at, I think that'd be great. Global primary care research is another area. So David has already talked about that, but I think in Guyana, like everywhere else, that's a big area of need. And the family medicine program in Guyana, I have learned, is transitioning from 3 years to 4 years. And in that 4th year, there will be increasing need for teaching and training in leadership, management, quality improvement. And so this is another area where we could potentially collaborate and be supportive. So that's what I've got. There's lots more that we could talk about the Guyanese program, and I'm sure our colleagues have lots of other ideas of of areas that they'd like to discuss, but this is just a sort of introduction of the program as we imagine our re-engagement going forward. Thanks.
That's amazing, Lisa. And in view of a discussion, we have 10 minutes because we wanted to leave enough time. It's hardly enough time, but I did want to see and welcome Tamika, Crystal, Kian, Prashad, Anisha. Thank you so much for joining us. And if you have any comments, please feel free.
David, Melissa, thank you so much. Yes, if anybody has any comments, please jump in. Maybe I can start. Just really maybe a plug. Felicity Goodyear Smith and the Maori team in which she works. They'll be presenting their primary healthcare work at NAPCRG this November. So that's really a session or a keynote really to not to be missed for sure. I did just a point around primary healthcare within Canada. David, heard on the CBC News that Nunavut there is still a suicide crisis. And you know, just the work as you were talking about the role of primary health care and the work that's going on right now in terms of mental wellness, like community mental wellness teams, you know, sort of adopting, you know, this approach that you're speaking about. And maybe if you have any comment about that and the roles that we can play here.
Well, two comments. What I'm often asked, why do this work when there's so much need in Canada? And my response is yes, we can and must do both, because the lessons across contexts is where the gold is. I still travel to Attawapiskat. I'm bringing a resident from the University of Ottawa to Attawapiskat in August, or he's joining me there. You know, I think the richness is in comparing contexts. So that's my first point. The second point is, yes, how much more could we achieve? It drives me crazy when I leave clinic, evening clinic, and I see homeless people around the clinic who don't have access to care. How much more could we achieve with that community orientation, as the CHCs do, right? So they have a community mandate, and this is a bit easier to understand in remote settings. That community mandate is much more obvious. But it really comes down to not only will, but resources, doesn't it? I mean, those graphs I showed around of maps around the world can be shown within Canada too, as you know, Doug. A liter of milk in Attawapiskat is $10. A liter of Coke is $1. So it does come down to resources, economic opportunities, and partnership. You know, that nothing about us without us, and it really is about partnership. And again, as I started my lecture, we have so much to learn from Nunavut as well, right? So if we engage with that kind of spirit, I think we'll see progress. I see Michael has his hand up. Nice to meet you, Michael. Yeah.
David, very nice to be here. Greetings. Michael Burke's my name. I'm speaking to you from Tanzania on the slopes of Mount Kilimanjaro. Tanzania, beautiful place. Yes, I joined late, I apologize, but some of the things I've heard are very exciting. I was very interested in the argument of the importance of family medicine in the transition from low-income countries from very low-income countries to low and middle-income countries, because that's Tanzania's situation. We've just made the transition. We're also seeing an increase of mental health, so that was a very good argument made. And my colleague from Guyana made the very interesting comment that there's a high retention of family medicine trainees as against others. So in our context, all of those things are very much very important for us to understand. So thank you for the opportunity of listening and learning.
And we'll learn a lot from you, Michael. Thank you for your engagement in Tanzania over many years. Michael is an Australian GP, and I look forward to meeting you in person in a month. Tamika, Anisha, is there anything that we haven't mentioned that would be helpful? You are on our radar. The pandemic unfortunately hit us, but we're here. and we hope to do more.
Well, I've got a question for Alyssa. In the Guyana program, I saw research there being an area of need of interest and in terms of capacity building, and just wondering if there's anything that I can do to help support.
Thanks, Doug. Yeah, I think that is a question that might be better answered by our Guyanese colleagues. Similarly to our family medicine program, their residents need to do a research project as part of their program. So I think this might be an area with potential for support. But as we continue to discuss the needs with our Guyanese colleagues, I think it'll become more clear what the needs are. So thank you.
Very good.
Hi, good morning. Sorry, I got logged off just now.
Welcome,
I didn't
welcome.
hear your question. Yeah, so good morning, everyone. Just to express thanks for inviting us to your grand rounds today. And just to reiterate what Dr. Beer said, even though we are here, we have support of our core faculty, we're still through Georgian Hospital, there's still a lot of gaps that we have. We would need support in, especially when it comes to our curriculum development. And research is another area that we would really appreciate the support, not only with conducting the research, but in terms of getting publications, because that's an area that we're not getting anyway with in Guyana. They had been talks of having a journal, but I don't know when that will be. So if we can have some collaborations and means of having a partnership to do research and assist with getting publications. And of course, the observerships. And we always welcome you here. I think we're very hospitable, so we look forward to residents and faculty visiting Guyana whenever you are ready.
Thank you.
And just to note, we have some residents here too on the call from Guyana.
Oh, good.
From faculty. Yeah, so we have Dr. Denicia Williams. She is soon to be second year. We have Dr. Francine Wins. We have Dr. Omar Ramnares, Dr. Shonit Waterman. I think it's about 12 or 13 people in total.
Wow, you're the majority.
Yes, yes, you have a lot of people from Guyana. Say hello.
Well, everybody, I can see that we are at hour now, and I would like to first of all thank David and Alyssa for your presentations this morning. And I thank all of you for joining in, either close by or far away. Just to let you know that you're always welcome to Family Medicine Grand Rounds. Wide variety of topics that are chosen each month. We will be taking a break for the summer and starting up again in September. So our next session will be on September 25th. So please do tune in. And thank you for all of you who have been joining over the past year. I think it's been a very good year for Grand Rounds presentations and a lot of engagement within our community. So thank you all very much. If you do have a chance, please fill in our little presentation evaluation. That would be most helpful. And I wish you all a wonderful summer.